Good afternoon. I am Deana Baptiste, and I currently serve as the Director for Cancer Screening Guideline Development at the American Cancer Society. Thank you for inviting the American Cancer Society to participate in this meeting. Today, I will be discussing updates in cancer screening with an overview of the American Cancer Screening guidelines for 5 cancer sites, and also doing a sort of overview on the impact of the COVID-19 pandemic on cancer screening, where we are and what we can do going forward. So let's start by discussing some of the recommendations that we have for cancer screening. In 2015, the American Cancer Society updated our guidelines for breast cancer screening. The starting age for breast cancer screening is 45. We issued a strong recommendation for women to start screening at age 45. However, we also recommend that women age 40 to 44 have the opportunity to start screening with a mammogram every year. Now, the interval for mammography screening is still annually for women 45 to 54, or for premenopausal women. And as part of our guideline, we recommend that women over the age of 55 or postmenopausal women could switch to biannual screening or have the opportunity to continue screening annually, depending on their personal preferences. And screening should continue as long as the woman is in good health and have a life expectancy of more than 10 years. Now, those recommendations are for women at average risk. There are women who are at high risk for breast cancer who should follow other guidance for screening. We classify persons who have a lifetime risk of about 20 to 25 years or greater as having a high risk for breast cancer, and this calculation is usually done with risk assessment tools that are based mainly on family history, and these include women with known or family carriers for the BRCA1 or BRCA2 gene mutation, or we also have other genetic mutations such as Li-Fraumeni syndrome, Cowden syndrome, or having a first-degree relative with these genetic conditions. The screening strategy for these women is usually to begin annual MRI at around age 30 and having a mammogram every 6 months. Now, for colorectal cancer screening, we updated our recommendations in 2018, and at that time, we decreased the age to initiate colorectal cancer screening to 45. Our recommendation is for adults age 45 years and older to undergo regular screening. And a key part of our recommendation was that you could have screening with either a high sensitivity stool-based test or a structural exam, depending on patient's preference and the availability of tests in the clinical setting. And of course, we recommend that screening continue through the age of 75, depending on health status and life expectancy. And our recommendation is that screening be discouraged after the age of 85. Again, just to reiterate, our recommendation emphasized test choice because the belief is that the best test or the best cancer screening test is one that gets done. So either of these 6 tests is perfectly acceptable for colorectal cancer screening. However, a key part of our recommendation is that all positive stool-based tests be followed up with a colonoscopy in a timely manner. Now, again, these recommendations are for persons who are at average risk for colorectal cancer. We acknowledge that many individuals are at higher risk for colorectal cancer and will require different screening strategies. Example, persons who have a family history or a personal history of polyps, colorectal cancer, or inflammatory bowel disease, or hereditary syndromes. They can all, these factors can all contribute to a high risk of colorectal cancer. Now, for these persons at higher risk, risk assessments and for colorectal cancer screening in the clinical setting is key. And though the American Cancer Society does not have guideline recommendation for screening persons at higher risk, we support the recommendations from other organizations, primarily specialty organizations that do have recommendation for screening persons at higher risk for colorectal cancer. And a risk assessment, is very difficult in the clinical setting, and we want to provide some guidance. So this algorithm that you're looking at, though it's not very readable on your screen, it was developed by the National Colorectal Cancer Roundtable, of which you may know that the American Cancer Society is a co-sponsor. And you may find this on their resource page. And it goes through how you can do risk assessment in the clinical setting to decide if you have a patient who may be at higher risk for colorectal cancer, and what screening strategy is best or is recommended for that patient. So I do encourage you to check it out at your earliest convenience. Now, cervical cancer screening, we updated recommendations last year in 2020. And we have new guideline for guideline recommendations for starting screening at age 25. Previously, we recommended screening starting at age 21. The preferred recommended test for cervical cancer screening is now the primary HPV test every 5 years. However, we acknowledge that this is not yet available in all clinical settings, so we still recommend that women get screened with a co-test, which is kind of a 2-in-1 test every 5 years that's commonly available in the marketplace. And of course, the traditional Pap test is still an option for screening every 5 years. And women over the age of 65 may stop screening if they have had regular screening and no positive results in the past 10 years. Of course, as with all these recommendations, there are persons who are at higher risk for disease who may want to, who should be screened differently based on discussions with their healthcare providers. So we encourage personal decision-making or individual decision-making about screening for persons at higher risk. Now, lung cancer screening guidelines were published in 2013 by the American Cancer Society, and we did a bit of clarification in 2018. However, we are in the process of updating our guideline, which is expected out in early 2022. In the meantime, we are suggesting or recommending that the guidance from the U.S. Preventive Services Task Force and other organizations for lung cancer screening with low-dose CT scans be followed, because there has been a recent update in the evidence that support these guidelines. And also this recent update in the evidence makes the American Cancer Society guideline from 2018 outdated. And that's for persons to start screening at age 50 if they're in fairly good health, currently smoke or have quit in the past 15 years, or have at least a 20-year pack smoking history. And a key factor in our lung cancer screening guideline recommendation is that persons who undergo lung cancer screening do get counseling on quitting smoking if they're currently smokers, and they also have to go through an informed decision-making process with their healthcare providers, and also that they're in fairly good health to undergo treatment for lung cancer if their test is positive. Now, for prostate cancer screening, our guideline has not changed in many years. It is one for informed decision making for men who have at least a 10-year life expectancy. And this informed decision making should include information about uncertainties, risk, and the benefits associated with screening. We recommend that men start this process at around age 50. However, for men at higher risk, particularly African American men, and those with a first degree relative diagnosis with prostate cancer before age 65, this process of informed decision making for prostate cancer should occur at a younger age, at the age of 45. Now, before 2020, we were making some great progress, I believe, in cancer screening. There was success with the 80 by 18 program in improving rates for colorectal cancer screening, and for breast cancer screening, mammography. About 2/3 of women were up to date on mammography, and for cervical cancer screening, over 80% of women were up to date on screening. However, shortly after the pandemic was declared in March of 2020, to mitigate the spread of the virus, you may recall that the CDC recommended a suspension in non-urgent healthcare. And this included routine cancer screening, and the American Cancer Society and other organizations supported this halt in preventive healthcare, including cancer screening. Now, unfortunately, what happened is that in a very short period of time, the pandemic shifted healthcare demands and delivery, and this shift resulted in a drastic decline in cancer screening. In just a few short weeks, we had over an 80% decline in breast and colon cancer screening, and lung cancer that which had a very low uptake. Even before the pandemic, we saw almost 40% decline just in the early part of the lockdown. Now, why does this matter? The hallmark of cancer screening is that regular screening, with regular screening, it's more likely to find cancer early. If you find cancer early in their stage of diagnosis, it's better for treatment and survival for cancer. And also there's the prevention potential from screening with the removal of precancer cells with cervical and colorectal cancer. So these missed screenings that we saw during the pandemic, there's a concern that these could lead to delayed diagnosis and care, and consequently an increase in excess deaths due to misdiagnosis and late stage disease. Now, just to give you an overview of this, this figure is from the 2021 American Cancer Society Facts and Figures, and it depicts the potential impact of the pandemic on future cancer outcomes. As you know, there was a reduce in access to care. And though non-urgent care has resumed, in many places we're back up to where we were before the pandemic, some individuals will continue to delay preventive care and follow-up of symptoms that they may be experiencing due to fear of exposure to the virus, other factors such as loss of employment and other and employer-based insurance these are all factors that play into the delay in seeking care. So while the social distancing measures and postponing non-urgent care were necessary, these delays in cancer screening will likely result in a subsequent short-term drop in diagnosis, which we have some data that showed that was the case, where we have just drastic decrease in cancer diagnosis, and there was no reason for us to believe that, suddenly, we weren't having, as people weren't having cancer before the 6 months after the pandemic was declared as they did before. Anyhow, these ramifications could last for a long time. And just to show you, we are projecting over 5,000 excess breast cancer deaths and 4,500 excess colorectal cancer deaths over the next 10 years, just from the pandemic. And although these are model-based estimates, it is still a cause for concern. So we have seen some rebound since the summer of 2020 in cancer screening and cancer uptake. And if you're interested in this topic, I suggest that you check out some of these articles that will further discuss where we are. But we do have still much to do up to this first quarter of the year, the beginning of 2021. We are still seeing about a 13 to 25% decrease in screening for breast, cervical, and colon cancer. And this data is from EPIC. So, we do have much to do in this area, and we do not yet know the full impact of that the pandemic will have. But the good news is that the American Cancer Society has launched a return to screening initiative. We started in 2020, and we're continuing. Our return to screening initiative is a very comprehensive approach, and we are using these three principles as our guiding principles for return to screening. And first and foremost is that despite the challenges that we face with the pandemic that is still ongoing in many areas, screening and care for cancer is still a public health priority, and we must be attentive to this. Now, I want to draw your attention to some information that the American Cancer Society has produced for effective messaging about cancer screening during the COVID-19 pandemic. Although time does not permit me to go into details, I do encourage you to access our comprehensive cancer screening page, where you will find information both for public-facing activities that we are currently undergoing, and also resources for our stakeholders in the clinical setting. We also have a hub on cancer.org that you can visit for up-to-date information on cancer and the COVID-19 pandemic. So just to wrap up today, I want to draw a bit of attention to the increase in cancer screening and just cancer care disparities that will likely be a challenge as a result of the pandemic. The factors that we saw in the pandemic, where we have certain subgroups in our society that were disproportionately affected by the pandemic. And these include persons who are under-resourced, and also persons of color. We have data that show that African Americans and Hispanics were disproportionately affected. Unfortunately, these factors also carry over into cancer screening and cancer care. And we're concerned that, these numbers of systemic and social challenges that's not just have to do with the pandemic will continue to manifest themselves as we go forward. and we will need to address them in order to increase screening rates in subgroups of our population that historically have not had full participation in cancer screening, and also have uh, not fully participated or fully had the opportunity for cancer care. So our challenge is that as we move forward in the post-pandemic era and we are promoting cancer screening during and after the pandemic, that we identify groups in our community who are historically had low cancer screening prevalence, and make these groups the benchmark for our success for increasing cancer screening, both at our local level, because that's where, especially at our local level, because that's where it's most important. Now, areas of impact for the underserved that could be a factor for you to follow up locally is screening participation. We know that stool-based testing, for example, for colorectal cancer screening is used in a lot of low-resourced area, but follow-up is an issue. Community-based research and engagement are important, and advocacy. So whatever you can do in your local area, please reach out to us at the American Cancer Society for our support, and we will assist you in developing programs or point you to resources that can help us address equity in cancer screening as we move forward. Thank you. This is my contact information. Please reach out to me if you have any questions. And again, thank you for having me today.